for joining in. It's Dr. Matt Love with the Urology Group. Thanks for taking some time out of your evening to join us. We're going to talk about one of our favorite topics to talk about. I'm sure for those of you who have tuned in, have had the joy of experiencing a kidney stone at some point in the past, or family members who have, and kind of figuring out, what are options? What can we do to avoid this? What are some causes, and what are some of our treatment options for kidney stones? So we'll dive right in. First, just a little bit about me. I am a urologist within the urology group. I am up primarily in the Fairfield, Hamilton area. I do have an office in Ross as well, and primarily operate out of our ambulatory surgery center in Norwood. Originally from Northern Kentucky area, so able to come back to the tri-state area. Unfortunately, hopefully there's not too many Ohio State fans on tonight after the beatdown that Notre Dame took in the national championship game, but I guess we'll stay tuned in if you are an Ohio State fan. Did my medical school down in Louisville, a year of general surgery at Vanderbilt and Nashville, residency for urology up in Washington, D.C. at Georgetown, and then ultimately able to come back home. One of the other reasons I wanted to get involved with some of the webinars, particularly with kidney stones, is that really has become a passion of mine. It really carved out a little bit of a specialty within our group. We recently have brought kind of the most invasive stone surgery called a PCNL, which we'll talk about tonight, into our ambulatory surgery center down in Norwood, which has been incredibly exciting. We were the first in the state, probably within several states, to create this as a purely ambulatory surgery center-based procedure. I focus a lot on kidney stones, surgical management, medical management, which obviously is the topic of conversation tonight. I do a fair amount of oncology, non-muscle invasive bladder cancer, robotic kidney surgery, robotic reconstructive kidney surgery, BPH or enlarged prostate, as well as some overactive bladder, vasectomy, and general urology, but really with the focus on kidney stones. So, with that, we'll dive in a bit more and kind of jump into, what is a kidney stone? How often do these things happen? So the kidneys are two bean-shaped organs that live kind of in what we call the retroperitoneum, sort of in the flank on either side. Their job is to filter waste and additional fluids and electrolytes from the blood to create urine. We'll show some anatomic pictures here shortly. And kidney stones are actually a composition of different crystals that form together to form a solid structure. Sometimes these will just be sitting simply in the kidney, not causing much of a problem. Other times they will drop into the ureter, which is the drainage tube that goes from the kidney, which drains urine down into the bladder. So this is a really thin tube. Generally, when people think of kidney stones, it is a stone that's been lodged within the ureter, which typically causes obstruction of urine flow, which ultimately causes pain or more severe infection, which sometimes requires urgent or emergent surgery and can get patients pretty sick pretty fast. These are typically the patients that come in through the emergency department that need emergency surgery or even end up in the ICU with very, very severe infections. Unfortunately, about 1 in 10 people will develop a kidney stone at some point within their life, which is why this generally is one of the more popular talks that we give because of how common and how high of an incidence this is. So again, just kind of a visual representation. If you look at the picture here, that outer sort of reddish pinkish area is what we call the cortex or the parenchyma of the kidney. So that's kind of the area of the kidney that does all of the work of the organ, filtering the blood and turning it into urine. You see that inner funnel portion with actually multiple kidney stones sort of lodged in there. That's what we call the collecting system, an area called the renal pelvis, which then drains down into the ureter. And so kidney stones really come in a wide variety of sizes, ranging from really tiny crystals, small, 2 to 3 millimeter stones that are able to pass to a golf ball, or really something that's essentially filling the entire inner portion of the kidney. And so we'll kind of talk a little bit more about the basics, types of stones, certain dietary things we can do, and then really jump and explore some of the surgical options and some of our newer surgical options that we have. So typically, if you have ever passed a kidney stone or you've had surgery, ideally your urologist would have sent a stone analysis off if you were able to capture those to get a better idea of what those stones are made of. Most common type of kidney stone is made of calcium oxalate. Obviously, the components of this primarily are calcium as well as oxalate. Oxalates are in a lot of different foods and drinks, which we'll dive into more detail. A lot of leafy greens, chocolate, tea, dark soda. Patients with really, really low calcium diets or really, really high calcium diets, as well as patients that are a little bit more dehydrated. And that'll be one of the themes is dehydration. As we're doing workups for kidney stones, we find that that's probably one of the most common reasons for forming kidney stones, but certainly there are some dietary components which can lead patients to have a higher chance of developing a kidney stone or getting a recurrent kidney stone. Uric acid stones are a less common type of stone, but usually we see that in patients who have really high purine diets or really high animal protein diets. Those generally are softer stones. They're a little bit unique because they are harder to see or not actually seen at all on x-rays. They're still seen on CT scans, and there are some advantages to them being a little bit softer and kind of relying on the acidity or the alkalinity of urine to increase or decrease the prevalence or even partially dissolve those. Struvite stones are less common than calcium oxalate and uric acid stones. These are generally in patients with really bad recurrent urinary tract infections. The reason these can be more of a challenge is if you don't completely remove these stones or you leave portions of these stones, patients tend to continue to get more and more infections. They still can cause obstruction like the typical stones, but generally see that in more patients that are having recurrent pyelonephritis, recurrent upper urinary tract infections. And then one of the other less common stones is a cystine stone. These are really, really hard stones. They tend to be common in a condition called cystinuria, which is a genetic disease, not very common, but just something on the wide spectrum of different types of stones that you can have. So as we mentioned before, about 1 in 10 patients get kidney stones. There is a little bit more of a likelihood if you're a man versus a woman of getting a kidney stone. There certainly is some genetic component to it. We're sort of in the infancy of figuring out how much genetics play a role or how exactly we can use genetic profiles, genetic testing to really optimize patients, to screen them, to figure out how we can prevent them from having future stones. I think we're, again, at the very early stage of this. I'm very excited to see where we go with this over the next 5 to 10 years. Again, we mentioned before, patients that are not drinking a lot of water that tend to live a little bit more dehydrated. These are patients that do tend to have a higher likelihood of stones. And again, a wide variety of dietary triggers, patients that are eating, very high animal protein diets, high calcium diets, high oxalate diets. High sodium in your diet can also trick your kidney into excreting a bit more calcium, which then puts you at higher risk for some of these calcium-based stones. Some other things that are a little bit unique, we, especially around the time of the pandemic, there were a lot more folks taking zinc and vitamin C. Patients that are taking really super therapeutic doses of vitamin C, that can actually be converted to oxalates, which can then set you up for calcium oxalate-based stones. So patients, again, with really high levels of vitamin C can be a problem. Other patients who have had other abdominal surgeries, gastric bypass tends to be a common one. Patients with Crohn's disease or ulcerative colitis can also have, due to their inflammatory bowel disease, are actually at higher risk for developing calcium oxalate-based stones, mainly just based on changes of absorption of your intestinal tract. Multiple other medications can cause this as side effects. There's a migraine medication named Topamax, which we oftentimes see as a big offender of this. And again, some of the common medical problems that we see in the United States, high blood pressure, diabetes, obesity, kind of go hand in hand with increasing the risk factor of developing a kidney stone. Most people who have kidney stones, I won't say all, but a vast majority get the traditional kidney stone symptoms that everybody fears and everybody hears about. Or if you've had it once, you're never going to forget it. So this is the sharp stabbing pain, this colicky pain that tends to come and go in waves. Usually it starts in the flank or in the back, but it really can present in multiple different issues, ranging from the back, radiating into the front of the abdomen, into the lower abdomen, radiating into the labia or into the testicle or into the lower bladder. So really, because the ureter, that drainage tube, gets nerves from all over the belly, you can get this referred pain sort of all through the back, leading all the way down into the groin. Some patients will present with really severe pain, nausea, vomiting, fevers, and chills. typically when we see those fevers and chills, these are patients that are potentially getting very sick very fast, that can get septic and develop a bacteremia or bacteria that gets into the bloodstream. And these are the sick patients that end up needing emergency surgery and end up in the ICU, or ultimately actually can be fatal. So these things are not to be messed with, and we take these things very seriously, especially in the setting of an infection. Some patients might have less in terms of the pain and nausea, and may just have a little bit of blood in the urine, or a bit more frequency or urgency, or just some discomfort with urination that just happens a bit more acutely. The common thing that we hear is, I constantly feel like I need to go, but nothing's really coming out, but that wave of urgency really comes on. So occasionally, if you get a stone that gets lodged in the bottom part of the ureter, right by the most sensitive area of the bladder, that can certainly cause more of those urinary-based symptoms. And again, every kidney stone is different based on the degree of obstruction, if there's infection present or not present. So some patients that have really, really tiny stones may have no symptoms. Some patients that have the exact same size stone may have 10 out of 10 pain and be in agony and make 2 or 3 trips to the emergency department. Some other folks with much larger stones sometimes don't have any pain at all. So there's not necessarily a direct correlation between the size of the stone at all times. It's more of, is the kidney obstructed? Is this a non-obstructing stone that's sitting in the kidney, or is there potentially, associated renal problems or kidney-related insufficiency or high-grade obstruction? So the first thing that we tell everyone is really hydrate well. Whether you're trying to pass a stone or whether you're trying to prevent a stone. There is a test that if you've had a stone before, I would recommend doing, especially if you're a frequent flyer and have had multiple stones. There's a 24-hour urine collection called the litho-link, which I think is quite helpful in helping patients understand how they can reduce their risk further. So my line that I tell patients is, you want to be creating between 2 to 2.5 liters of urine output per day. So whatever that takes you, however much fluid you need to drink to get to that point where you're creating about 2 liters to 3 liters of urine a day is where you need to be. Generally sticking with water. Lemon juice and water can be helpful. We try and avoid sugary drinks like sodas or darker sodas, which can be higher in oxalates. In general, we do tend to see a little bit more of an increased prevalence in the summer, mainly because people are more active, they're hiking, they're exercising, they're outside, they're sweating, they're just running a little bit more dehydrated and maybe not thinking to drink as much water as they typically were when you're sitting around and not doing these activities or not sweating significantly. Additionally, again, we had mentioned before, lots of different foods. If you really want to dive into the weeds, the Harvard School of Public Health put together a way too exhaustive worksheet of different high oxalate containing foods. So if you're one of these people who likes to do their own research, you could Google that. I believe it's a Microsoft Excel worksheet that really looks into a lot of different foods, their oxalate content. So if you're more focused and really motivated to make some changes, I think that's a helpful tool. Spinach, nuts, lots of leafy greens, chocolate, a lot of unfortunately healthy stuff and good stuff to eat. This is not to say that you can't eat those things, but again, if you have a history of calcium oxalate stones and you have what we call hyperoxaluria or high levels of oxalate in the urine, paying attention to some of these high oxalate containing foods like tea or like dark sodas is also going to be helpful. The calcium game, it can be a little bit more of a challenge. With dietary calcium, we don't want you eating massive doses of, taking in massive doses of calcium in a real high dairy containing diet. We also don't want you being calcium deficient. There's other medical conditions that can go along with that. So we usually say, calcium in moderation. If you don't need to take additional calcium supplements, don't take them just to take them. Far too many times, I'll see patients that are taking in really high doses of dairy, taking a vitamin D supplement, a calcium supplement, a multivitamin that's got calcium. So really just paying attention to some of the calcium supplements or additional supplements that you're taking. Again, everything in moderation, protein in moderation. Really, really high levels of protein can mess with the acidity of your urine. It can also set you up for uric acid stones. And also, again, calcium-based stones tend to be higher if you're eating a lot of protein. We had mentioned before sodium or salt. Higher levels of salt will cause higher levels of urinary calcium, which again is just setting you up for more stones. And we had mentioned the vitamin C. doing that in moderation and not getting excessive amounts of vitamin C to decrease your oxalate risk. So how do we treat stones? A vast majority of stones do end up passing on their own. And really a lot of this, it has to do with the size and the location of stones. So typically when you're having your initial diagnosis, it's going to be something like a CT scan. That tends to be the most definitive way of diagnosing this. Now, occasionally we'll use ultrasounds and x-rays to monitor stones or to follow up things after surgery. But by and large, a CT scan is your first step. Generally speaking, stones that are less than 5 millimeters tend to pass on their own if they're lodged in the urine. Patients have certainly passed much bigger stones, and I've had plenty of patients that have had trouble passing 1 to 2 millimeter stones. But in general, the smaller stones that are farther down the ureter do tend to pass more easily. There's not an exact timeline on this. So a challenging question, patients will come in and say, I've been having this miserable pain for 3 days. Do I call you back tomorrow? How long do I wait? It's really on a case-by-case basis. And a lot of studies will say between 2 to 4 weeks it can take for these stones to pass. A lot of times we don't know exactly when these stones first started moving. Typically, if these stones are really dragging on, or the pain or the nausea or the vomiting are miserable, that's when we start talking a little bit more about surgical options. And stones that don't pass on their own, we generally will add in additional medications. Rarely there are ways of partially dissolving stones. Most of the time we're talking about surgical procedures to remove them. So when patients have stones that are passable size, or they're really trying to avoid a surgery with maybe a borderline size stone lodged in the ureter, typically we will prescribe a medication like Flomax or tamsulosin, which is what we call an alpha blocker. It's a medication that will relax the smooth muscle within your ureter, that allows that ureter to stretch out a little bit more, decreases kind of the contractility of the ureter. And in the combination of the medication with good hydration, that tends to allow these stones to pass a little bit more frequently. We obviously want to keep people's pain and nausea under control. There are a lot of centers that are moving away from narcotics overall. I do still think there's probably a role. This is one of the most severe types of pain that you can have. So it's usually a combination of NSAIDs, Tylenol, Advil, Toradol tend to help a lot. Sometimes you just need something a little bit stronger just to get over the hump and get this thing passed. And occasionally, if you have a larger uric acid stone that is within the kidney, there are medications like potassium citrate, which you can use that actually help dissolve these. Now, we don't typically use these for first line when you have a stone stuck in the ureter, but it is an option for other stones. The most common surgery that we end up doing in the United States and even worldwide for obstructing ureteral stones is something called ureteroscopy. So what that is a procedure that allows us to put a really small camera into the bladder, an even smaller camera that goes up the ureter, and allows us to treat that stone within the ureter. Typically, these procedures are same-day surgeries. We do the vast majority of them in our outpatient surgery center. Same-day surgery, send you home typically with a couple of days of pain medications and some of that Flomax to just help relax the ureter. The advantage of this is we're able to directly visualize the stones. We use a tiny little laser fiber to blast those stones to little pieces. If the stone fragments are small enough initially, sometimes we even use a little basket to extract those fragments and to really make sure that that ureter is clear. Now, if you've logged on to this talk, I'm sure stents are something that everyone here loves. We know that stents are no fun, but a stent is a little hollow plastic tube that essentially allows that kidney to safely drain past the obstructed area within the ureter and down to the bladder. And the challenge with stents is while it does give people pain relief, a lot of patients don't really like them. They tend to cause lots of irritating symptoms. I sort of liken it to having a urinary tract infection. I tell patients it's very normal to have blood in the urine, frequency, urgency, some burning. And typically, if you go home with the stent, there's a couple additional medications that your urologist can offer you. So if the ureter is pretty beat up, the downside is if we leave no stent, most patients will be back in the emergency department within 24 to 48 hours. Where that stone was lodged within that ureter, once we remove it, that ureter begins to swell up and blocks off, essentially replicating a kidney stone blocking that area again. So what we hate to do is bring you in for surgery and you leave in more misery, or you end up back in the emergency department and we end up having to emergently put a stent back in. and that just delays the whole process, and then you end up having a stent for multiple weeks afterwards. So for most of urologists, this ends up being a judgment call in the operating room. If they're smaller stones with less irritation to the ureter, I do my best to avoid stent placement. That's not always the case. Sometimes we'll put stents on strings that patients can remove at home to decrease the need for an additional procedure. Some patients will need a second look up the ureter if we can't easily get the scope up. Some ureters are quite narrow, so sometimes that stent has to go in to allow the ureter to narrow to keep the kidney safe, and then to allow our scope to go up at a later date to treat that stone. So there's a whole host of reasons, including injury to the ureter, infection, really narrow ureters or really swollen ureters. That stents really make sense. So most of the time, again, this is a temporary measure to just make sure we're keeping the kidney safe. Now, another really nice option for kidney stones is something called shockwave lithotripsy. This is kind of the least invasive procedure that we can offer you. So again, this can be used for stones that are in the ureter that are a little bit on the larger side. This also can be used for what we call non-obstructing stones in the kidney. And this is actually one of my preferred ways for smaller or medium-sized stones that are higher up in the ureter or even right there in the kidney. And so this is still a procedure similar to ureteroscopy that requires general anesthesia. It is still an outpatient surgery that takes about an hour. And what we do is use X-ray, typically not ultrasound, mostly X-ray to locate the stones. With that, we send these shock waves that go through the skin, aimed at the stone, fragment the stone into tiny pieces, essentially hoping to obliterate it to sand. So you pass these really small fragments. That way, there's no need for any incision in the back. There's no need for a stent that we have to put in. And typically, over the next couple of days, lots of stone debris and dust passes. Now, the advantage of doing this, number one, it is less invasive. Because we're not putting cameras internal, there's a lower likelihood of infection. There's a lower likelihood of us injuring the ureter. There's a lower likelihood of having a stent, which, again, I know makes a lot of patients happy. The downside to it in some cases is the location can be a little bit of a challenge if it's moved a little bit farther down in the ureter. With really large stones, it tends to not make sense. With really, really hard stones, there tends to be a little bit of a higher likelihood of only partial fragmentation. So the trade-offs with the invasiveness tend to be that it's probably a little less definitive than a ureteroscopy where we're directly staring at the stone, lasering it to small pieces. But in many, many patients, this is a really good option, or at least invasive first option, to try and break up some of these stones. When stones are getting bigger and bigger, the next option is really one of the more invasive and most invasive type of stone surgery called a PCNL, or a percutaneous nephrolithotomy. So we call it a PCNL to just make it a little easier to pronounce. A PCNL is a stone surgery through the skin. So percutaneous means through the skin, nephrolithotomy means breaking up of stones. So this is a procedure, we'll show you a video here in just a second, but essentially this is for the larger or more complex stones that are mainly sitting up in the kidney. There's a small incision that's made in the lower part of your back. We typically use the help of a radiology doctor to get access into your kidney. Some urologists will get their own access. And instead of just putting scopes up from below, we're putting a much larger instrument in what we call an access sheath that goes into the kidney and allows us to really efficiently break up stones. Fortunately, we have converted this to be primarily an outpatient surgery. I had mentioned before we were one of only a handful of centers in the country that were doing these at our ASC. We do these at the hospitals as well, but typically outpatient surgery with a tiny little incision to get people, kind of back on their feet sooner rather than later. In the good old days before I was practicing, you'd have a really large incision that would wrap all the way around the flank. Those were horribly painful incisions to kind of open up the kidney and remove large fragments. Now we have really efficient instruments that will allow us to break these stones up efficiently. And the reason for doing this over the shockwave or the ureteroscopy is it's just a lot more efficient. Rather than needing a multiple stage procedure to break up the stones with either a ureteroscopy or a shockwave lithotripsy, this is kind of typically a one and done procedure unless you have a really complex stone that's essentially filling the whole kidney. So here in a second, we'll pull up a video that kind of goes through what a PCNL surgery is. So it's about a 2-minute video that just kind of goes into a little bit more detail, and I'll try and annotate things. So Again, typically we do this in conjunction with the interventional radiologist. So the first aspect of this surgery is actually getting access into the kidney. Sometimes the radiologist will actually ask us to give them a little bit of help getting through the skin into the kidney itself. So there are ways of us doing a really minor first look procedure where we put a small wire or a small catheter that goes up the ureter, which we're seeing here, all the way up into the kidney. There's contrast dye that we can shoot through there, or sometimes even what we call a balloon occlusion catheter that will sort of block off the urine flow, allow us to see a little bit better where all those calyces or those little pockets are. Once we have a better idea of exactly what calyx we want to access, the radiologist will stick a little needle through the skin into the back, and allow us to pass some wires and get what we call safe access into the kidney. You can see that kidney stone that is there. Typically, kidney. Sometimes we'll let that tube stay in place for a couple of days to just mature the tract. Other times we'll dilate that kidney up. We stretch the kidney out. It allows us to get a much larger instrument in there to really efficiently break it up. Occasionally we'll use things like baskets, what you see there. Occasionally we'll use lasers to break things up. Fortunately, the technology has really been growing in the kidney stone space, over the last several years. A really nice device is something called a trilogy, which is a device that allows us to use ultrasound and pneumatic compression to really evacuate stone fragments, remove everything. And the hope is if we get you completely stone free, we're able to remove this sheath that is within the kidney. Typically, in my practice, I'll try and remove the tube out from the back so there's nothing hanging out through your back, and put in an antegrade stent, meaning a stent that is placed through the kidney down into the bladder. And you can see the little curl down there at the bladder. Generally, once we have access into the kidney, this procedure, can take an hour to 90 minutes. If it's a less complex stone, we've done these in 20 minutes. If it's a more complex stone, it may take a couple hours to get things clear. So again, that's kind of the most invasive stone surgery, but also the most definitive. So, the challenge is every stone is different. Every patient is different. We have patients that are much larger that make PCL more of a challenge. We have patients who are on blood thinners, which make it impossible, if not very, very challenging, to poke a big hole in their kidney, stretch out their kidney, and do a procedure like a PCL. And really, with ureteroscopes and with standard ureteroscopy, there haven't been a ton of innovations really until probably the last 2 to 3 years. We've been seeing a really big movement towards more types of suction scopes, and newer devices. So, again, the scopes themselves cannot remove fragments. The lasers themselves cannot extract stone fragments. Baskets cannot break up stones, and sometimes have challenge, getting into different nooks and crannies of the kidneys. So there is a new technology, which is called CVAC, from a company called Calixo. Fortunately, our group and myself have been part of really the early days of Calixo and the CVAC device, dating back to the end of 2022. I believe our surgery center was the second place in the country to actually do the new CVAC 2.0 procedure. So it's been a really exciting time in stone care where there's been, it's been quite stagnant, to be very honest with you. So a really exciting time to be involved with stones. And again, we were part of an early market experience, not only using their Gen 1 device, but also using their Gen 2 device. And we'll kind of go into a little bit more detail on some other videos here in a bit. But with this CVAC Shore device, the Shore procedure is what we call a steerable ureteroscopic renal evacuation. So this is an all-in-one scope that allows us to break up stone fragments and evacuate them through a steerable ureteroscopic catheter, all in a single procedure. So really the goal is, how do we pick the right procedure for the right patient to render them as close to stone free, if not stone free, if possible. Nobody likes passing those stone fragments afterwards. Trust me, us urologists hate it just as much as you when we get a call and say, hey, I passed a bunch more fragments and ended up in the ER because I was passing a bunch of dust that you left up in my kidney. And really, traditionally, we haven't had many options, if any options. The nice thing about CVAC is, in general, it actually makes a lot of larger stones and kind of borderline more complex stones. The surgical time is quicker. So most of the time, these procedures are under 1 hour. My average surgery time is less than 1 hour. Occasionally, for much more complex stones, these can last a little bit longer. But again, this is a procedure from a patient standpoint is very similar to ureteroscopy in terms of what to expect around the time of surgery, very quick recovery, outpatient surgery. And so this is just a quick picture of the device and the processor with it. Again, really a game changer and a paradigm shift when it comes to stone care. So with the all-in-one system, it allows us to have a built-in ureteroscope that allows us to break up stones, extract stones if we need them. It has all-in-one irrigation and allows us to aspirate and collect these stone fragments so that we can analyze them. This is, again, kind of getting into the nitty-gritty of the scope a bit more, but just another visualization of the scope that we use. So if you look at it, if you've seen a ureteroscope before, it does look quite similar to that with very minimal changes. But in fact, the scope is very intentionally designed differently to not just be a scope that happens to have a little suction on it. So with this device, there is a dynamic aspiration aspect to it. So we're able to control these pulses from these angled microjets, which are kind of these water jets that you see on the sides of the scope here. And the goal of that is to actually fluidize and allow these stone fragments to sort of almost turn into a fluid, because these stone fragments that we dust get so small. There's this passive aspiration that there's this constant sort of push and pull with irrigation flowing in and some suction and aspiration coming out of the scope. So a lot of the stone debris that typically we just leave up in the kidney without us doing much additional work at all is passively aspirated out during the lithotripsy or during the breaking up of the stones. The active aspiration is kind of a targeted vacuum extraction of these stones at the conclusion. So once we get these stones small enough, traditionally we'd say, well, they're less than 5. These patients should be able to pass them. Now we have a lot better equipment and technology to allow us to render folks stone free and not have to deal with those residual stone events, ER trips, secondary procedures, things like that. So this will be a little bit of a video, again, kind of showing you what the CVAC device can do. So again, similar to a ureteroscopy, the way that this starts is we put a camera that goes into the bladder. We typically will put a small wire or even an access sheet, which goes from the bladder, which we'll see here down at the bottom of the screen. Here's our wire going up our ureter and all the way into the kidney. Typically, we shoot some specialized x-rays, put an access sheath up, and then insert the device over this wire. This then allows us to use that flexible scope to identify the stones. And you can see in this case, there's multiple pockets of stones in different areas. We insert the laser, break up the stone fragments, and you can see those angled microjets allow us to keep everything in our visual field without blowing fragments all over the place. And even while we're lasering, we're able to extract a lot of those fragments at the same time very efficiently without doing any additional work. You know, typically we're just lasering these stones until we can't really see anymore. And that's been one of the limitations to ureteroscopy, especially for medium and large stones, is you get so much stone dust and debris that gets trapped up there. So after you break up all the stone fragments, we actually remove the laser and we have a larger outflow lumen, which allows us to aspirate out in more of a targeted fashion all of those stone fragments that we created. Now, you know, no one's going to promise you they're going to get you 100% stone free every time, but really the goal of this device is to get as many patients 100% stone free and to be a lot more confident when we talk with family in the recovery area or on the phone after the surgery and say, yes, they had a multiple pockets of stones or really, really large stones, and we were able to render them stone free. So from a patient standpoint, most of the time it's actually more efficiency in the operating room. So surgeons, we love efficiency. Patients love less time under anesthesia. Patients love less stone debris that they have to pass afterwards. So again, I think it's really been a paradigm shift. And if you look at some of the big wigs in urology across the US and the world, and a lot of our conferences, the American Urologic Association, the European Urologic Association, the uptick in suction devices, and particularly devices like CVAC, has really skyrocketed, where again, there's been a lot of stagnancy there, not a lot of research going into newer devices. And now we're really seeing this explode. And I think the patients ultimately are going to be the ones who truly benefit the most from this. And there's some really compelling 2-year data that's coming out on the CVAC device. A randomized controlled trial that was done on 100 patients with standard ureteroscopy versus actually the older version of CVAC, which was way less sophisticated and fancy than this. And we're seeing, not only less repeat stone episodes, trips to the ER. The overall health economics is much better because patients aren't needing new surgeries. Patients aren't needing to go to the ER, and we're really able to optimize those durable stone-free outcomes. So, not every patient needs a PCNL. Not everyone needs a CVAC. Not every patient is even a candidate for a shockwave lithotripsy. So, really, your treatment modality is very individualized. It's what type of stones have you had? What other medical problems do you have? Where are these stones located? How big or small are they? And again, we have some patients that want to avoid a stent at all costs. They might be a patient who a shockwave lithotripsy makes sense. We might have patients who can't get off blood thinners but have a really large stone and really need a PCNL but can't. And that's where CVAC, I think, sort of fills this medium to large stone role. But we're even seeing some really compelling data with stones around a centimeter, sometimes even a little smaller, that may benefit from a CVAC over the standard ureteroscopy. So again, there's a lot of excitement around this, and so I think really talking to your urologist, looking at imaging tests, kind of looking at your own personal history and figuring out what makes the most sense in each case. And we understand that it's not always I have a stone that I have plenty of time to think about what I want done. Most of the time it's I'm miserable and I'm in the ER and I just want this thing out as soon as possible. So it's definitely something to bring up to your urologist. I hopefully this was educational and provided a little bit of a foundation of different treatment options and other aspects of kidney stone care. Going back to that comment, if you do end up in the ER in the middle of the night on the weekend, call our offices, let us know. We've tried to really streamline things because we know kidney stones are horrible. On the very front page of our website, there is a link if you have a kidney stone, where we will sort of put you to the top of the list and get you plugged in. If not, an in-person office visit. We have multiple providers, including a dedicated APP who kind of works on our kidney stone line and really expediting stone surgery for patients who may need it. So if you're ever in doubt, and you're not really sure, and maybe it's taking you longer to get in, or it's a weekend and you don't know if you can get an appointment soon enough, log onto our website. There's plenty of great resources there where you can get in touch with us sooner rather than later to get these problems addressed. So again, open to any questions that you may have. I see a couple that have rolled in here, so I'll start rolling through these. But if you have any questions, feel free to send that in through the chat. So do fluid recommendations vary with age? My bad answer is yes and no. In general, I'll go back to what I said about the litho link, and we like to have patients that make 2 to 2.5 liters of urine a day. Now, if you're a patient with a bad heart or with bad kidney disease, you're not going to be able to hydrate enough safely to prevent other issues with your heart. So each patient, it's a bit individualized. If you're more active, if you're less active, if you're sweating more, if it's hotter out, all of those things can sort of impact your fluid intake overall. Chronic stress causing kidney stones. There is some data to say that might cause problems. Now, is that going to cause a stone to leave your kidney? No. I have had patients that said, hey, I went to Kings Island, I rode on the bumper cars, and I know I had a stone sitting in my kidney, and that night I started having pain. Yeah, maybe a little bit of trauma to the kidney caused it. We always tell people, it's easier said than done to manage chronic stressors. We don't necessarily say if you have a kidney stone, you got to avoid Kings Island or ride on a roller coaster doing bumper cars, but it can be a bit unpredictable if and when these stones cause problems. So this is another conversation to sort of have with your individual urologist. Are these stones big enough where if they drop, might they cause a problem? And is this something that we would benefit from just watching with an x-ray, or is this something that might benefit from doing a little bit more? So I'm going to scroll down here a little bit more, see what other questions we have. All right. So any suggestions with hypercalciuria in pregnancy? So yeah, that's a challenging question for the venue, but patients in pregnancy have been studied a lot. There are certain aspects of pregnancy that actually are protective, and there are certain aspects of pregnancy that will set patients up for kidney stones. So the other challenging thing is we really want to try and avoid general anesthesia and surgery, during pregnancy. So in general, going back to hydration, that's kind of the biggest thing that we can recommend at that time. You can't typically get routine x-rays and CT scans. So oftentimes we're relying on patient symptoms and ultrasounds to check those things. There are certain medications that can actually decrease some of your urinary calcium. So that would be something to work with your OB and your urologist to see if that's something safe to take during pregnancy, especially again, if you're a chronic stone former and worried about that. There are some what we call thiazide diuretics, which can be helpful. Great segue into our next question. Any suggestions, for dissolving stones? So in patients that are uric acid stone formers, there's a medication called Uracit K or potassium citrate, which will change the acidity of your urine. That tends to be the best way of doing it. Some people have been able to use sodium bicarbonate. That really doesn't taste as good and can cause some high blood pressure issues. So we don't routinely use that. Another question, does lemon juice work? Lemon juice will actually increase your urinary citrate, which is protective. So in patients who have hypocitraturia, where they have lower levels of citrate, or who have uric acid stones, that can be helpful. I usually tell people to just, the cheaper, easier way is get the green jug of lemon juice, do a tablespoon or two every single day, and just kind of make that like it's a daily multivitamin. Another really great question with the CVAC procedure is that something that requires a stent. If you ask 10 different urologists, you may get some different answers. At the current time, the answer is yes, I generally end up stenting people. Now, might that change in the future with more data coming out? I think there's a very strong possibility. I have done CVAC where we have left patients unstented, but the scope is very, very minimally larger than the standard scope, and we put in a little bit of what we call a larger access sheath that's just a few tenths of a millimeter bigger. The challenge is if you have an access sheath or a larger scope up there, it does cause a little bit more irritation to the ureter. So in general, when you have a CVAC, a high percentage, probably 95% of urologists are going to leave you with a stent afterwards, at least a stent on a string, if not an indwelling. I try and leave as many on strings as possible, just so patients can get them out sooner. But in general, we do, by and large, leave them with a stent. It will be interesting to see if there's more studies coming out to say that it's safer. Again, the last thing I want to do is have my patients end up in the ER and they're not too happy with their ER bill and they're not too happy with their urologist who could have just left a stent for a couple of days. So yes, another question, since kidney stones generally are a recurring problem, can the CVAC procedure be done repeatedly? The answer to that is yes. Just like a standard ureteroscopy, hypothetically, you can have this procedure done as many times as you need. Now, obviously, we always try and avoid surgery if possible, because every time that we're traumatizing the ureter, putting a scope up there, you can cause some damage or increase your risk of developing a stricture or scar tissue. But just like other procedures, many times as you need it, you certainly can have it. Again, we try and avoid procedures or optimize you with your initial procedure, whether it's a PCNL or a CVAC. Another question, sort of clarifying, what is the difference between lithotripsy and Calyxo? So the Calyxo CVAC device is just a different device. Lithotripsy is just a broad way of saying breaking off the stone. So laser lithotripsy is anything where we put a scope up into the kidney, use a laser to break up a stone. So we still do laser lithotripsy with the Calyxo CVAC device. We just use a different scope. So most of the time when I talk to patients, I either say, we'll do the standard laser lithotripsy or we'll do a CVAC or SHORE procedure, which is essentially just that newer CVAC scope, which allows us to, again, facilitate more significant passage of stones there. If you have stones in both kidneys, can the CVAC treat both kidneys in one procedure or 2 procedures required? Another good question where if you ask 10 different urologists, you may somehow get 10 different answers when there's only 2. In my practice, in general, not all the time, but in general, I don't like to do both kidneys at the same time. Patients that have 2 stents like us even less than patients who have 1 stent. So your bladder doesn't really love it. And if there were some issue with a kidney, or God forbid we operate on 2 kidneys and you have some sort of complication, all of a sudden you're going into renal failure or having multiple stents in versus doing the safe thing, clearing one side. Now, if you have a small stone that's lodged in the ureter on one time, most of the time you're going to have urologists that will be able to address both at the same time. Now, CVAC, we're not typically using on smaller stones. So if you do have really large stones, the other potential complicating factors, if we're dealing with really large stones in both kidneys, we also don't want to have you under anesthesia for 3 or 4 hours while doing an endoscopic procedure. That's going to increase the risk of potentially having increased pressures or temperatures, or an increased risk of sepsis or an infection the longer we're up in the kidneys doing work. So if it's a more straightforward case, I will occasionally do bilateral ureteroscopy. In general, I try and be a little bit more conservative and clear out one side at a time, especially if we're working higher up in the kidney. If they're in the ureters, generally we're trying to get those ureters clear, and that kind of takes the priority. Another question for clarification: is ureteroscopy the same as cystoscopy? No. So cystoscopy means we put a scope into the bladder. A ureteroscopy means we're putting a scope into the ureter. So it's still a camera that goes into the urinary tract, but the cystoscope is meant for the bladder. The ureteroscope is meant for the ureter. Another question: what percentage of patients have stones return? So it was interesting. We were actually talking about this right before we kicked all this off. When I have patients come in for their initial stone visit, I tell them, the reason I want to be more proactive with prevention here is about 50% of patients who have a kidney stone episode will have another one within 3 years. So in this case, I really like to be proactive. And if any of my patients are on here, if I've seen you in the past for stones, usually I'm asking you to come back with ultrasounds immediately after surgery, or even doing x-rays every 6 to 12 months afterwards. So there does tend to be a little bit of a higher likelihood of developing another stone moving forward. With that, let's see. So is there a relationship with kidney stones and ED, erectile dysfunction? No, there's not. Do you have issues with insurance paying for CVAC? So anytime that we have a new procedure, there's always hoops that we have to jump through. And I think I had mentioned some of the 2-year randomized controlled data that's coming out. A lot of the insurance companies are seeing the improvement in the healthcare economics of how this actually probably saves them money long term if you're going to the ER less, if we're able to clear stones more efficiently. Early on, there was more issues with it just from a provider standpoint. A lot of those kinks have been worked out. There are still some insurance providers throughout the country that we're still working on, giving them all of the data that we have. And at this point, there's really not a major insurance issue at all that we see sort of in the greater Cincinnati area. Another question: I'm having a ureteroscopy procedure next month. How do I know whether I should be having a CVAC or not? So this would be something to reach out to your primary care doctor, your primary urologist. They would be the ones that either had told you or had booked it as a CVAC. So with that, I would call the office. Again, if you have a small stone that's lodged in the mid portion of the ureter, or the far portion, what we call the distal portion of the ureter, you really don't need a CVAC. That can be dealt with standard ureteroscopy. Now, if you do have some stones that are more medium to larger, that are up in the high part of the ureter, the proximal ureter, or the kidney itself, that would be a very reasonable question to call your urologist office and say, what can I do? Do I need a CVAC here? Are you one of the providers? Fortunately, due to our group here in Cincinnati being involved very early on with the CVAC device, we probably have 2/3 of our providers and most of our providers who are doing more high volume stones who all have access to this. I've gone and talked to urologists sort of all across the country, and there's extremely variable practice patterns. And we're just now starting to see a really big uptick in some of these CVAC procedures. So fortunately here in Cincinnati, honestly, we were one of the first areas in the world that had access to this device. I had bladder stones flushed out a few weeks ago. Should those have been analyzed? I have a follow-up scheduled 6 months. Is there a way to find out these results? So, bladder stones usually are formed a little bit differently than ureteral or kidney stones. Some urologists will send those off. If you've had something in the past, they may not have. A lot of times the bladder stones themselves are due to prostate-related issues or incomplete emptying of the bladder issues. So again, you could always call your urologist office to see if they've analyzed any of those stones. Are vitamin D supplements helpful to absorb calcium and reduce stones? So my hedge answer here, without giving you a straight answer, would be everything in moderation. We need vitamin D and calcium so we don't get osteoporosis, we don't get osteopenia, we don't have vitamin D deficiency. Now, if you're really low on calcium, you're actually at higher risk for stones. If you're really high on calcium, you can be higher risk and an elevated risk for stones. So it can be a challenge. Oftentimes us urologists, we're laser focused on how do we keep you out of the operating room and what can we do to prevent that next stone episode. Oftentimes it's a combination of discussion with us, discussion with your primary care doctor to say, hey, do the risk outweigh the benefits? Does it make sense for me to do a vitamin D and calcium because of my osteoporosis? Oftentimes it still makes sense to do that. And that's sometimes where we can, have more of a conversation about how do we maybe implement other dietary changes, or maybe we wash your kidneys a little bit more frequently with maybe an x-ray or an ultrasound. Can renal colic happen if there's not a stone in the urine? So generally you have it if you have a stone that's going through or blocking, but patients, renal colic is just a fancy way of saying colicky, cramping pain within the ureter. So if you've had a stent in place, you can have renal colic, even if there's no stones. If you're having spasms of the ureter, you can have that. Now, it's uncommon to just have renal colicky pain in the absence of having a recent stone episode or an infection, but sometimes that can happen. Another question, do you recommend taking potassium citrate to help stop creation of stones? In certain cases, yes. Not every patient has uric acid stones. Not every patient has low levels of citrate in the urine. So it really is on a case-by-case basis. I wouldn't recommend just giving any patient who's a first-time stone former to really start potassium citrate just for prevention. If you've made multiple stones and your urologist has never mentioned anything to you, I would at least push them to make sure that you've had a litholink test in the past, which oftentimes can be helpful to really give more personalized information about, what exactly do you need versus, the guy down the street who's taking potassium citrate or taking indapamide or hydrochlorothiazide, which are again other medications that can really decrease your risk of recurrence. Let's see. Is the system reviewed today Gen 2, but the system used on me a year ago, Gen 1? So I don't know the exact patient here, but I was one of the first in the country using Gen 1. That was in October of 2022. Gen 2 has been out for about a year. So what we showed today is kind of the up-to-date version, the Gen 2. If you had a surgery about a year ago, it could have been either of those. If it was in the last 6 to 8 months, this was definitely the Gen 2. Again, the Gen 1 was just a bit more cumbersome for urologists. It's still kind of got the same outcome as we can see from a lot of the early data. That even with the more challenging device without direct visualization of the kidney, it was quite successful. Another great question. I find managing my diet to prevent calcium oxalate stones quite difficult. Have you referred patients to dietitians? So I think it would be fantastic if there's any dietitians on the call right now to have somebody that we have within our own group. We have so many patients with stones. I do think it's beneficial if you're really having trouble from a dietary standpoint, you're a recurrent stone former. It's easy for us as urologists to say, here's a list of all the things not to do. Now go figure it out and try and find a diet that isn't just drinking water and eating cardboard. We get it. It can be a challenge. So, again, there are some online resources in general, stone diet tips. I believe at one point I looked into Kroger. Kroger had some online dietitians, and this is not just a shameless plug for the local company, but they did have some online dietitians, which were free to access. Depending on which health system you go to locally, a lot of the health systems will have access to dietitians. So, if you have that litholink test that has some more information about what types of stones you're forming or what your urine parameters are and kind of what your urologist counseled you on, I do think if you're a recurrent stone former that just can't quite grasp or can't kind of get to that next level of stone prevention, I think dietitians are an incredibly useful tool. Is lemon juice good for all types of stones? Not necessarily. If you have low levels of citrate, it can be protective. If you have uric acid stones, it can help partially dissolve. Sometimes if you mess with the acidity of your urine too much, you can create other types of kidney stones. So again, this is where I think really the customized approach is more useful rather than a one-size-fits-all, whether it's stone prevention, whether it's dietary changes to make, or whether it's the type of surgery. So again, really, I think the important thing is kind of having those data points, talking with your urologist. What kind of stones do I have? what aspects of my urine test are setting me up for stones, putting that complete picture together to really help optimize prevention and ultimately avoid having to deal with any of these fun surgeries we talked about today. So, again, if you're one of those folks that's making stones, how do we increase the time interval before your next stone episode, or how do we choose the surgical option that's most optimal for you to decrease the likelihood that you're back in the operating room a couple months down the road. So, well, thank you guys so much. This was really engaging. Thanks for all the questions. I think that makes these webinars a lot more interesting, both for me and for the other patients on here. So if there's any other questions that pop up, let us know. If you're having stone, issues right now, currently, I'm obviously always taking new patients, and we have a whole bunch of urologists that are very skilled in taking care of kidney stones, whether it's CVAC, whether it's PCNL, whether it's shockwave lithotripsy. There's ways to request an appointment. There should be hopefully a pop-up that came up on your screen. But like I mentioned before, if you're ever having an acute episode and you're having trouble, getting in rapidly, there is the online option to click on that link and to get in sooner. So really appreciate everyone taking an hour out of their night to talk about one of my most one of the most exciting topics for me. I really love doing these surgeries. I really like the satisfaction of helping patients feel better. I see how miserable people are when they're having kidney stone pain or when they're having to undergo multiple procedures. So whatever we can do to help in terms of prevention or optimize surgical experience, we're here to help. So give us a call, reach out. Happy to see any of you guys. And again, thanks for spending your night with us and taking some time. Have a great rest of the night.